Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today our topic of discussion is about non-infectious scleritis. So this is the anterior segment photograph of a patient, 29 years old patient with Wegener's granulomatosis, suffering from the red eyes for almost 3 months. You can see here the deep ciliary congestion all around the eye. And superiorly, you can also see some pannus formation. And his vision was 20/20. He was myopic. And this is his anterior segment photograph. You can see there. This is his inferior view of the eye. Here again, you can see that red inflamed eye with deep ciliary congestion. Another view of anterior segment, left eye. You can see the pannus formation and how the ciliary vessels are congested and inflamed. And there is also pannus formation from 2 o'clock to 10 o'clock. So this is another temporal view of the same patient. You can see here how deeply congested and red inflamed eye, even in this sector. So this 29 years old patient, when presented to us, he was already under the treatment of rheumatology department. He was taking azathioprine, Imuron, 100 milligram, which was later increased to 150 milligram, and he was taking corticosteroids, oral prednisolone, 60 milligram, for his treatments for Wegener's granulomatosis. And if we talk about his blood workups, he had antinuclear antibodies positive and PR3 was also positive. So this patient also developed redness of eye, which was for some time, and then he presented to us. On examination, it was found out that this patient was suffering from anterior scleritis, non-infectious, considering his history also and blood works. So this patient was treated as he was already on azathioprine, Imuron. So this patient was again put on oral corticosteroids, prednisolone, because he had this problem of eye, remission attack of the redness of eye, when the dose was decreased to 20 milligram from 60 milligram. So this patient was dose was increased, and after consultation with the rheumatology department, we introduced this patient to rituximab, and we followed the protocol of rheumatology protocol, which is 1000 milligram rituximab 14 weeks apart, and it was decided to give him 2 doses 2 weeks apart and the other doses after 6 months. So after that, this patient showed good improvement, as he was earlier not responding with the full dose of azathioprine and even with oral corticosteroids. He was showing remissions on decreasing the dose. So he showed good response, and you can see in the further photographs that his condition is now better. Here you can see that red inflamed eye is no more. There is no more congestion, and the blood vessels which were inflamed have subsided. Pannus is still there. This patient has definitely, because of the use of corticosteroids oral, he has bilateral cataract changes. That is there. But if you talk about the condition, it is much better than before. This is his anterior segment, latest photograph. The eye in the cross section, slit lamp, you can see well controlled, quiet eye, no activity, and the patient currently, once the treatment has been given, 2 doses of rituximab. Now this patient is on the tapering dose, maintenance dose of prednisolone 7.5 milligram daily, along with topical cyclosporine eye drops. This is another view. No more inflammation, no more activity, quiet eye. But if you see superiorly, you will see some thinning of the sclera. Yes, there is some thinning and you will see bluish discoloration under it. This is usually normal with scleritis. There is thinning of the sclera and underlying uvea gives this color over there. So definitely you will find in superiorly some areas of patchy bluish discoloration. This is another anterior segment photograph showing the eye. There are few blood vessels you can see linearly going along the panas, but they are not inflamed. The anterior segment of this patient recently was quite no activity. This is the right eye of the patient, which was not affected right from the beginning. Only the left eye is involved. So just to show you the view over there, there is no more activity, but just you can see maybe some cataract changes are present in both eyes, even in the right eye. That is because of the chronic use of steroids, which is understandable. Scan was done ultrasound to see any posterior segment inflammation on ultrasound, any T sign for the scleritis posterior. It was negative. No such thing was found even in the ultrasound. CT macula, right eye, no macular edema, no intraretinal fluid, no thickening, normal contour. As I mentioned earlier, this patient showed very promising and good results with the rituximab. Rituximab is basically an antibody which basically attacks the B cells and it causes depletion of these B cells in the peripheral blood. While affecting the peripheral blood, it also decreases the B cells in the tissues. But it does not affect the plasma cells, so the antibodies are still produced. But the response because of the B cell depletion to this disease controlling is very much effective. So this protocol we followed here, as was the rheumatology protocol. But while giving the rituximab, we have to keep an eye on the blood works, liver function tests, because there is sometimes a reactivation of hepatitis B. There is also possibility of having other problems with the rituximab, although controversial, that the reactivation of tuberculosis in endemic areas. So quantiferon can be done for these things. So it is very effective treatment modality, especially if the patients are not getting controlled with corticosteroids, and you have also tried, for example, azathioprine, Imuran, you have tried tacrolimus, cyclosporine, cyclophosphamide. So after that, if the patients are not responding, they can be given a trial. These are very effective in controlling scleritis, although there is still, you will find almost 8 to 9% patients we will have some resistance to this medication, but it should be tried, it should be used under the close supervision of the rheumatology department. The treatment protocol I told you was the three types of protocols. One is the rheumatology, 1000 milligrams, 2 weeks apart, and then they go after 6 months doses. The other is the oncology protocol, 375 milligram per square meter body area, they give 4 doses. Then there is a Foster protocol for 8 doses. So all these things are there, but we usually do it under the close supervision and cooperation of our rheumatology team. And this patient showed wonderful results. I wanted to share with you that the thing which was not getting controlled, when we decreased the dose of the steroids to 20 milligram, there was a remissions. So it was very effective. So I just wanted to show you the results of this treatment modality. So now coming toward the scleritis. Scleritis can be of different types. It can be infectious, it can be non-infectious. But as our topic of today's discussion was mostly focused on the non-infectious, so it may be anterior scleritis, which may be diffuse, nodular, necrotizing with inflammation, and necrotizing without inflammation like scleromalacia perforans. And it may also be posterior scleritis. Talk about the immunosuppressives and non-infectious. They are the mainstay of treatment, steroids, or you're using alkylating agent, or these antibodies you are using, whatever, azathioprine, cyclosporine, tacrolimus, cyclophosphamide. even rituximab. These are the mainstay of treatments along with the conventional oral corticosteroids. But if you talk about infectious type of scleritis, then you have to treat the root cause of that microorganism which is damaging the eye. And under that cover of the antimicrobial agents, these can be introduced immunosuppressants. But otherwise, these are contraindicated. Now, if we talk about the exogenous scleritis, it may happen because of the trauma. Patient has undergone some surgery, that one. Eye has developed keratitis. And if we talk about the endogenous scleritis, it may happen because of the tuberculosis and syphilis. If we talk about the non-infectious causes, the leading causes are rheumatoid arthritis and granulomatosis with polyangiitis, Wegener's granulomatosis. These are the leading causes. Whenever you are encountering a patient with non-infectious, these should be also screened. The top priority, these should be there. If we talk about the non-infectious causes, the leading causes are rheumatoid arthritis and granulomatosis with polyangiitis, Wegener's granulomatosis. These are the leading causes. Whenever you are encountering a patient with non-infectious, these should be also screened. The top priority, these should be there. Talk about the histopath of this non-infectious scleritis in autoimmune. They have found that there was an element of the necrosis of the collagen fibers. Then they also find the neutrophil cells over there with some histiocytes, but there was no signs of infection. And there were some elements of vasculitis and some giant cells were found over there. But if we talk about the idiopathic scleritis, there was no necrosis over there, but there was some chronic inflammation, lymphocytes, plasma cells, lymphocytes, and histiocytes were present, granulation tissue and fibrosis was there. So this is briefly about the histopath of this non-infectious. If we talk about its presentation, it is usually insidious in presentation and severe intensity of pain, and which is usually not responding to the non-steroidal anti-inflammatory drugs. The pain usually radiates towards the forehead, brow, ear, or even to the jaw. And even if you touch the eyeball or even if the movement is there, patient will feel extremely discomfort. But if we talk about the scleromalacia perforans, the patient will have no pain. Nodular type of anterior scleritis, you will find a nodule over there with thinning of the sclera, and there will be underlying some visibility of uvea. And if we talk about the posterior scleritis, if it involves the posterior segments, then you may have optic disc edema, you may have macular edema, and cilio-choroidal detachment can even happen, choroidal thickening, mass and folds, all these things once the posterior segment gets involved. A few steps to differentiate infectious from the non-infectious. If there is infectious cause, you will feel purulent exudates, you will see ulcers, abscess, scleritis with hypopion. You can go for culture and staining, and Monto syphilis serology, and antimicrobial therapy. And steroids are usually contraindicated in these patients. And if we talk about some features classical of the non-infectious, as I earlier mentioned, they are not associated with pus, abscess, they will be diffuse, nodular, tender congestion of deep blood vessels with edema of the sclera over there. And you can see these do the blood works, anti-nuclear antibodies, ANCA, rheumatoid factors. This is a classical, which is the blood workups. And usually, as I mentioned, in these types, we use the steroids or steroid sparing agents. So these are the few points to make a quick differentiation. This was the presentation for today, in which we discussed, if we conclude that the patients who are resistant to the classical treatment protocols of the steroids, they can be put on these immunosuppressants agents, especially Even if this azathioprine and the tacrolimus, all these are failing, you can introduce the rituximab, the antibodies which affect and control the humoral immunities. I hope this presentation will be beneficial for you. I want to thank my respected audience for their attendance and attention. Thank you.